Hi, everyone. I am here with Dr. Craig Taylor. We're going to be discussing a topic that's very close to my heart, and that is reflux after weight loss surgery. Dr. Craig, thank you so much for joining us today.
Thanks, Damo. Thanks for the invitation to be on your podcast again. It's a pleasure to speak with you on a very important topic.
Yeah. So we've been talking a little bit this morning about reflux, and I guess it is a topic that I find important because it's something that I'm going through, and I know a lot of other people suffer from it. And really, whether it's a mild discomfort or something that is really impacting our daily lives, understanding it, I think, is part of the key to being able to deal with it properly. And something that I've found is that even with all the amazing medications there are out there, they don't always the meds don't always do enough to control the reflux. And Dr. Craig, you've had a fair bit of experience with treating people with reflux. So, would you like to tell us a bit about uh, the experience that you've had to start with?
For sure. Reflux is an interesting area, so a special area of interest for me personally as an upper GI surgeon. All my training and surgery is on the stomach organ, the esophagus, and the junction in between, which of course is the anti-reflux valve. So reflux is something that uh, I've been involved with on a regular basis now for more than 20 years. And just some background around reflux. Reflux is common in the community. One in two people in the community will experience reflux symptoms at least once a week. And there's a spectrum of severity. So that might just be a transient mild episode of heartburn that might be precipitated by spicy food or caffeine, right up to daily symptoms, regurgitation of fluid into the back of the mouth every night, requiring propping up the head of the bed of the bed of head, or taking a lot of medication to try and control the gastrointestinal fluids from refluxing. So the whole spectrum there. And one of the things that's associated with reflux is obesity. People who carry too much weight are at higher risk of having reflux.
Yeah.
And that's in part because of the fact that when we carry extra weight, it's disproportionately carried in the abdomen. So the abdominal compartment becomes higher in pressure because of the extra fat tissue being carried. And that tends to force stomach content up into the esophagus in the chest. So that's why there's a strong association between obesity and reflux. And to the point where 2/3 of people with who have a weight problem would have regular reflux symptoms. There's a further association between some of the weight loss procedures that we do and reflux. So that deepens the problem that patients who already may have reflux seeking help with their weight then may have a weight loss procedure that further exacerbates their risk of reflux. And one example of that would be the gastric band procedure where reflux was very common. Another example would be the sleeve gastrectomy. And so the association between reflux and obesity is complex, and there is a strong association. So that's some background. You mentioned medications and how they don't always uh, help or alleviate the symptoms, and that makes sense. And I'll tell you why. And that is because anti-reflux medications all target one thing, and that is they lower the amount of acid being produced by the stomach. That's all they do. The stomach has other fluids though in it. So there's pepsinogen, there's bile, there's pancreatic enzymes, there's gastrointestinal fluids. And the medications that control acid production do not do anything to reduce the production of those other fluids. So we can have full acid suppression and still be having reflux of fluid from the stomach up into the esophagus.
Wow. I didn't know that.
It's an important thing, a lot of important concept to understand. really, and they also are a band-aid solution to the problem. What we really need to be doing is improving the function of the anti-reflux valve that we already have at the bottom of our esophagus that can become impaired. And so it can become impaired, for instance, if you have a hiatus hernia. A hiatus hernia is where the junction between the esophagus and the stomach moves up above the diaphragm into the lower part of the chest. If that junction is not in the right spot, which is at or below the diaphragm, then the anti-reflux valve doesn't function properly.
Right.
So rather than putting a band-aid on the reflux by treating with Somac or treating with Zantac or treating with Gaviscon, what we need to do is repair the structural problem that's causing it, if that's a hiatal hernia. Another example of a structural problem that might be causing the reflux would be a patient who's had a sleeve gastrectomy where there's a twist or a kink or a narrowing in that sleeve or an hourglass shape to that sleeve. That problem won't be fixed by medication. That problem can only be fixed by improving the shape of that sleeve or converting that sleeve, if it's beyond repair, to a gastric bypass, which overcomes the narrowing or the twist in the midsection of the sleeve.
Yeah, I mean, that makes perfect sense that, yeah, if it's, I guess, a structural issue, medications aren't going to fix that.
That's exactly right. So when we approach reflux symptoms as doctors, we approach it in a bit of a stepwise logical fashion. So the first thing we ask ourselves when we have a patient with reflux symptoms is it truly reflux? Because there are other conditions that can mimic reflux. So gallstones, ulcers on the stomach, and even cardiac problems can all mimic reflux. So it's important to make sure that it is reflux. And so taking a careful history around the symptoms, what exacerbates it, what relieves it, what is the location of the reflux symptoms being experienced is really important to teasing that out. But then we also need to use other investigations that will help clarify the symptoms. So one common investigation that we would start with would be an upper endoscopy. And that's where we put a tube down into the esophagus with a camera under twilight sedation and have a look at the lining of the esophagus and see if it's inflamed. And we'll often take biopsy samples of the esophageal lining to have them analysed by the pathologist under a microscope and see if there's evidence of inflammation. We also then can see if there's a hiatal hernia or not there. That's readily diagnosed at endoscopy. And the endoscopy affords us the opportunity to look into the stomach and the duodenum and see if there's other obvious problems there, like inflammation of the stomach lining called gastritis, or an ulcer in the stomach or an ulcer in the duodenum. So an endoscopy would be a very important first-line test or investigation in clarifying the symptoms. But then we can have other tests that will help in specific cases. So one example would be what's called a reflux isotope scan. And that's a specialized study that seeks to see if reflux is happening and reaching up into the throat or the mouth, or even indeed aspirating and going into the lungs. So the reflux isotope scan is where a patient will drink a special fluid that's got a harmless level of gentle radioactivity. They'll drink that, and then the patient will have a series of scans over the subsequent hours to see where that fluid is. And that fluid should not be back up in the throat or up in spilling into the voice box or down into the lungs. And if it is, that's abnormal. And that helps to clarify whether that patient's having a complication of their reflux known as laryngopharyngeal reflux that can lead to all sorts of problems like dental decay, chronic sinusitis, hoarseness of the voice, soreness of the throat, chronic cough that's often misdiagnosed as late onset asthma or adult asthma, even recurrent bouts of chest infections and pneumonias, all of which could be caused by reflux.
Wow. Because, yeah, listening to those symptoms, that's definitely my experience. And I think that's really important for people to understand as well that, there needs to be the right tests done to get to the bottom of what the symptoms are. And
I
instead of
agree.
just treating symptoms,
Absolutely. And coming back to that laryngopharyngeal reflux set of symptoms that I outlined before, they are often due to having volume reflux. And so it's not specifically an acid issue per se. Therefore, all those medications which we talked about before that only reduce acid production will do nothing for the volume. So the volume reflux, it won't matter whether the pH value of that fluid is raised toward being more neutral by the medication. If the volume is still going up into the throat and the voice box and the back of the mouth, it will still cause problems regardless of the medication. So that's why it's so important to tease out whether this is mild reflux, where the predominant issue is heartburn, which then can be alleviated by acid suppression with those medications, versus a more sinister problem, which is to do with volume of gastrointestinal fluid going into the wrong place, like the lungs and the mouth, which will not derive any real significant benefit by reducing the acid component.
It's I guess even for me, it's a little upsetting to think that, here's the pills, and still struggling every day with reflux, even though I'm on the medications for it. That you know it may not actually be treating the issue.
Yeah,
And
that's correct. I think these medications are used a little too liberally. There's also concern around the long-term use of some of these medications, and we've got concerns around the effect that the proton pump inhibitor medication in particular has on bone health, bone density,
yeah,
kidney function, but also the gastrointestinal health, because there are consequences of removing or reducing the acid by the stomach. The acid is there for a reason. The acid in the stomach is beneficial when it stays in the stomach. And its job is to improve the absorption of iron, improve the absorption of vitamin C, and also deal with ingested bacteria that may otherwise create gut infections. So
oh,
the suppression of acid in a long-term way also has its downsides.
yeah, makes perfect sense. I didn't realize that, and there have been times where my iron has been low, and that sort of stuff. I guess as we I suppose as science progresses, we're seeing or hearing more and more about gut health, and what's going on through the whole endocrine system, I guess, and how much one thing can affect everything.
That's right. That's right. So then the question I often get faced with in my practice is someone who's already had weight loss surgery and has developed reflux symptoms, and how we approach helping that patient. And so one example would be a person who might have had a sleeve gastrectomy. And the reason why sleeve gastrectomies are associated with reflux is because they have a higher pressure than a normal stomach. And that's a fundamental outcome of reducing the size of the stomach. When we reduce the size of the stomach substantially, typically around 80% with a sleeve gastrectomy, we increase the pressure in the stomach. That's a fundamental law called the law of Laplace. So that happens in every sleeve. Normally, that slightly higher pressure that then occurs is still able to be withstood by the reflux valve in most patients. So some patients, though, up around 10% of patients, will find that the higher pressure stomach causes reflux symptoms. And if that first instance to treat those patients would be to suppress acid, so the medications do have a role in the first instance. If that reflux is significant, though, and associated with those laryngopharyngeal symptoms up in the throat, or it's volume reflux causing actual volume of fluid to be regurgitated when bending over or at night time, then we need to do more than just the medication. And that means lowering that pressure in the stomach. So revision surgery is a way of doing that. So what we do with revision surgery is typically convert the sleeve gastrectomy to a gastric bypass. And that's because gastric bypasses do the exact opposite to a sleeve in terms of the pressure. They lower the pressure. And when the pressure is lowered, it means that the work being placed on the anti-reflux valve is then eased, and the gastric fluids are still made, but rather than going up the wrong way, they go down harmlessly the right way. So that's one important role for revision surgery, is to lower the pressure in patients who have got pressure-related reflux after a sleeve.
Yep.
Another situation, though, is where patients develop reflux years down the track after a sleeve. So they've had a sleeve gastrectomy, there've been no reflux symptoms initially, they've done very well with their weight control, and several years have gone by, and typically 5, 6 years, and then late reflux develops. So we see that pattern quite commonly as well. And typically what's gone on there is the patients have developed a hiatus hernia. So that as a result of all the weight loss, the supportive tissue around the junction between the esophagus, the stomach, and the diaphragm has become loose. The fat pads have become smaller through the weight loss. And so now that area has become lax, and the top of the stomach sleeve, migrates up into the bottom of the chest. And it only has to move by 2 or 3 centimeters for the anti-reflux valve to stop functioning properly.
Wow.
Often when that happens, 5 or 6 years down the track, it's accompanied by some weight regain as well. And so we've got a double problem. We've now got increased pressure in the abdomen from the weight regain, plus the development of the hiatal hernia from the intrathoracic migration of the top of the sleeve into the lower part of the chest. And so that then can lead to the onset of late reflux symptoms. In that situation, it is possible to fix the reflux by simply doing a hiatal hernia repair. So a laparoscopic procedure to bring that reflux valve back down below the diaphragm, combined with getting that weight regain addressed through maybe a re-establishment of appropriate dietary and lifestyle patterns, properly supported by a team, maybe with the additional benefit of some short-term use of the weight loss medications such as Wegovy or Mounjaro. So that's another approach to dealing with late onset reflux.
Yeah, I suppose it's this is where you really need someone with the knowledge to be able to guide you with all that, because I mean, I wouldn't even know, just as a patient, where to even start. And so what would your recommendation be to find, like, the right doctor to help you get started on this?
I think first and foremost, you need to speak with your surgeon that performs your sleeve gastrectomy, and let that he or she know that you're experiencing symptoms and that you'd like it to be investigated, and like to get to the bottom of it and treat it. So you will then get a sense from talking with your specialist whether they are proactive in ordering the right investigations and following you up regularly and to see how you're going, or whether they're taking a bit more of a dismissive approach, putting you on medication and saying, that's it, solved, see you later. So I think first and foremost, give your surgeon the benefit of and the opportunity of being able to address the problem. You've got a relationship with that surgeon, and that surgeon's got a duty of care to you to help you. But don't be afraid to get a second opinion. And I think that's true for everything, any condition in medicine, is feel empowered, feel confident in asking for a second opinion. Either ask your surgeon, could they recommend a colleague to get a second opinion from? And there's no shame and there's no embarrassment in asking that. But also do your own homework and find what surgeons in your area specialize in dealing with reflux, and don't be afraid to ask your surgeon or the second opinion surgeon what their experience is like in managing reflux, how many cases of revision surgery for sleeve gastrectomies that have got reflux symptoms have they done, and what have been the outcomes that they've seen in their experience with revision surgery to control reflux. And I think you'll then quickly get a sense as a patient whether you're dealing with someone who has specific expertise in this area or not.
Yeah, that's great advice. I think so many people just suffer in silence, thinking that, oh well, I'm on a medication now. I know for me, I've had different people say, well, oh, it must be something that you're eating. So then you start going through everything you eat, but it becomes almost unmanageable trying to even do that yourself, because oh, I cut this out and I didn't have any reflux last night, but then you might have the same thing to eat and you do have reflux. And like, okay, so was it that? Was it, and I know I've sort of had those discussions with myself, what did you have this time? But then it's fine next time. So
Yeah, it can be very unpredictable, can't it? And I think because there is an association between some dietary things and reflux symptoms, it's quite understandable that there is a focus on, well, let's keep a bit of a food diary. Let's get an understanding of what foods are exacerbating the symptoms and then minimize those foods. So that's very reasonable. But where it becomes unreasonable is where someone's got quite severe reflux symptoms and they're told that the solution is the diet, that they're at fault for their reflux. And the reason why they're getting ongoing symptoms is because they're not adhering properly to the correct diet to avoid those symptoms. That's unfair because there are situations of reflux that no amount of dietary change will resolve. They may be arising through a structural problem with their sleeve. They may have an hourglass shaped sleeve with a twist or a narrowing in the midsection, or too much fundus and width of the sleeve at the top. Or they may have a hiatal hernia. And you can't fix those structural problems through diet alone.
yeah, yeah. I think we, as patients, especially when it's to do with obesity and living with obesity, so many of us have become used to being blamed. We get blamed because we're overweight, because we're living with obesity, it must be your fault. So then it just becomes a natural a thing for us that, oh, it must be something you're doing that's causing it. And we just go along with that because, we've sort of been conditioned to believe that it is our fault. And it certainly isn't all the time. It's not always.
Yeah, totally right. It's a easy scapegoat and a bit of the old punching bag to say it's the patient's fault, isn't it? And there's no question that there's some factors that the patient could be contributing toward their symptoms. So it's not black and white. Certainly, it needs to be a combined role of patient and doctor working together to solve a problem. And there are certain things that a patient can do, but a patient can only take that so far. There is certain things that a doctor needs to do to alleviate the problem. And it's important to alleviate the problem of reflux because it's not just that it causes discomfort, it can also cause damage, it can cause harm long term. Patients can have dental decay and lose teeth, they can have chronic voice hoarseness and changes of voice, they can have lung damage from chronic aspiration, but they can also have quite uh, significant damage to the lining of their esophagus from the constant corrosive effect of the fluids rushing, contaminating the esophageal lining. And that ultimately can also lead to cancerous change. So reflux is not a trivial problem where it causes unwanted symptoms only. Reflux can be a lot more serious than that and cause long-term major health concerns, ultimately including cancer of the esophagus.
Wow. Yeah, so it's definitely something that we need to get treated when it's going on. But is there a way that we can work out if we're going to be more susceptible to getting reflux before we have a gastric procedure? Is there a way to go, okay, well, I want the sleeve. Is there something that the surgeon can do to say, well, I think you might be a bit more susceptible because of, or is it just a bit of a luck of the draw?
There are some tests that can be done to get a better understanding of a person's reflux risk based around understanding how well their reflux valve works right now before they've had a sleeve. So, as I mentioned before, sleeves increase the pressure within the stomach. And because that sleeve stomach is still making acid and other stomach fluids, those are now made under higher pressure. A normally functioning reflux valve and a normally functioning esophagus will be able to easily withstand that slightly higher pressure and not lead to reflux. So it'd be certainly wrong to think that all sleeves create reflux. They don't. All sleeves increase pressure, but the vast majority of sleeves don't get reflux, provided the sleeve is being constructed in the appropriate shape and size. And secondly, that the patient's anti-reflux valve works properly. So to answer your question, is there anything we can do to get an understanding of whether the person's going to be more at risk of developing reflux after a sleeve or not? That would be about evaluating that person's anti-reflux mechanisms to start with. So there are some tests such as one called impedance pH manometry. And that test is a test to work out how well the esophagus contracts and how well it clears and how well the gate at the bottom, that sphincter muscle at the reflux valve at the bottom, the esophagus closes, and whether there's already any reflux happening before we even do the sleeve. So that's one test that can be done, but it's a fairly specialized test that's not readily available. So some other tests that can be done that are a little bit more available include an upper endoscopy. What an upper endoscopy can do is see if there's any silent existing reflux already happening, or whether there's a hiatus hernia that might be putting the person at risk of having a poorly functioning reflux valve. And that may not be symptomatic while they've got a normal stomach, but the moment you give them a sleeve gastrectomy, that could create symptoms. So that would be one way of getting a sense of risk of reflux after the sleeve gastrectomy. And indeed, many surgeons will do that routinely prior to offering a bariatric procedure as a screening tool to see whether perhaps a gastric bypass might be a better alternative for that patient.
Yeah. So it really comes down to asking those questions.
I think a careful history it goes a long way. A careful asking the right questions as part of your consultation with a patient who's considering having weight loss surgery will give a better understanding of whether we need to then go down those investigative pathways or not, and do those more specialized tests so that we can give the right treatment to the right patient.
Yeah. No, I think that's great. I think for patients, the more that we're educated and quite often we don't know what questions to ask if we don't know what questions to ask. And, I think that's important to get that out there that, we can, and it's okay to ask questions from our medical teams.
Absolutely. I love it when patients ask questions, and I love it when they ask questions specifically about my own level of experience and results. I think it's important that patients feel comfortable and confident and empowered to do so. Because at the end of the day, it is the patient's body, it is the patient's right to understand what is proposed to be done to them, know more about the person who's potentially going to be doing that
Yeah.
operation for them. So, with one take-home message, I think that everyone listening should get from this podcast today is feel comfortable and confident to ask your surgeon any question you like, including questions about their level of experience.
Love it. I think that's important. I think we need to be able to go in knowing that we've not just asked the questions, but that we've been heard with our own anxieties or our thoughts going into it. And I think the more information that our teams have, the better equipped they are to help us.
Yeah, I agree. I agree. And coming back to the sleeve and reflux, we said that yes, the sleeve increases the pressure within the stomach, and that can lead to reflux emerging as a result of the pressure in approximately 10% of patients. But there are things that we can do at the time of performing a sleeve gastrectomy to minimize any risk of reflux. So we talked initially about what tests can be done in the lead up to surgery that might help us identify if there could be any patient factors that put them at higher risk. But as separate to patient factors, there are technical factors as well that are important that we take into account as sleeve surgeons when we're performing a sleeve. So they are, for instance, looking for and fixing any hiatal hernias that might be there. And they can sometimes be quite subtle. They can be obscured by having a lot of fatty tissue around the top of the stomach and the bottom of the esophagus. But it's important to make sure that the junction between the esophagus and the stomach is at or below the diaphragm. and that the diaphragm opening that allows the esophagus to come through is at the appropriate diameter. It's not stretched out and loose. And if we do find a hiatal hernia, it's able to be fixed at the same time as performing the sleeve gastrectomy. So that would be point number one. A technical factor that's really important is, does your surgeon look for and repair a hiatal hernia if found at the time of surgery routinely or not? Do they have confidence and experience in doing that or not? The second thing would be the importance around the middle of the sleeve of not stapling too close to the bougie that we use to size the middle part of the stomach is a very unique area. It's got a name. It's called the incisura. The incisura area is susceptible to being narrowed when we're doing the stapling for a variety of different reasons. And it takes deliberate conscious awareness of that. When we correctly perform a sleeve gastrectomy, we deliberately go a little bit wide of that corner before coming back in toward the bougie. That's absolutely fundamental, that we don't lead to any narrowing, twisting, or kinking or distortion around that middle part of the stomach called the incisura. The third thing that's important is the proximal or top part of the sleeve not being left too wide. So there's an area of the stomach called the fundus, and that fundus makes acid, and it's very thin-walled and easy to stretch and distend. It's crucial that that part of the stomach be included in the removed part. We don't want to retain any fundus on the top part of the sleeve. If we do, then we have acid being produced right up under that reflux valve, and that area tends to stretch disproportionately compared to the rest of the stomach over time. So that only compounds the issue over time. So there are some technical considerations that as surgeons we need to be aware of and take into account when we're performing a sleeve gastrectomy, so that we don't add to the risk of reflux over and above that intrinsic rate of 10%. That's to do with the high pressure that comes with the sleeve gastrectomy.
Yeah, it amazes me that we've come so far with all our procedures and stuff, but there's still so much more education to do, I guess, with for patients understanding even the experience levels of their surgeons. And so the sleeve can still be a fantastic procedure. And there's something that gets brought up in our groups a lot is, why are sleeves still done if everyone gets reflux? But that's not really the case, is it? Not everyone gets reflux if you have a gastric sleeve.
Absolutely, and that's important. So 90% of patients who have a properly constructed sleeve should not get reflux. So overwhelmingly, patients can have a sleeve procedure and have no reflux and have a trouble-free, great quality of life. So I think another real important message here is it would be completely wrong to associate sleeves with reflux in every case. It's not true. So the majority of patients can do very well with a sleeve gastrectomy, have no reflux, enjoy great weight control, great medical improvement, and a great quality of life. And that's why we still do sleeves, because they are a very low risk, safe, and simple procedure. Gastric bypasses are an alternative to a sleeve gastrectomy, but they do carry their own problems, their own side effects long term, such as dumping syndrome, nutritional risks of ulcers to the joint between the stomach and the small intestine, changes in bowel habit, the risks around small intestine being obstructed or kinked. Those risks are all totally avoided by having a sleeve gastrectomy. And that's why it remains a very popular procedure. Indeed, in Australia, 80% of patients having weight loss surgery will have a sleeve. Around the world, it's around 70%. So overwhelmingly, patients have sleeve gastrectomies because they are safe, they are simple, and they avoid a lot of these problems that can be associated with the more aggressive forms of bariatric surgery. But there is reflux. Reflux is the one issue with the sleeve, but can be managed and can be at a very low level, provided the patient's properly screened and provided the procedure is properly carried out by an experienced surgeon.
Yeah. Do you find people getting reflux after a bypass?
Yes, they can. And that also It's less common, but it can occur, and it can occur for technical reasons. For instance, if a hiatus hernia is not recognized and addressed at the same time, then even with a bypass, you can get reflux. Or if the pouch that's created for the bypass is made too big and it's secreting acid, that can cause reflux. Or if the way the second joint for a Roux-Y gastric bypass is constructed, if there's a narrowing or a partial obstruction at that joint, then bile and pancreatic juices can still reflux back up into the gastric pouch and into the esophagus. So reflux occurs in the literature in up to 20% of patients with a gastric bypass, despite the fact that we all feel that the gastric bypass is a cure for reflux. It can also cause reflux if not constructed in the correct way. And that's the important thing, that the construction of the surgery and the technical factors are crucial for this issue of minimizing or avoiding reflux.
So I think one of the themes that I've been picking up during this conversation is the the construction. And how would you suggest to a patient, because most people don't want to offend the person that they're talking to, how would you suggest a patient approaches a surgeon on their experience?
I think it's very reasonable to ask straight out, how many of these procedures have you done? And what percentage of those patients have had reflux? The second thing you should feel absolutely comfortable in asking is if they can provide you with the contact details of a previous patient that they can have a chat to.
Oh, I love that. Yeah, I really like that idea, and I think that would be so helpful to know that, okay, this is the surgeon that did your procedure. How do you feel about it? Yeah, I think that's such an important thing, and because it is a life changing procedure, and you really don't want to just be jumping into it with the first, you know, oh, we're just going to do this later, and not really understanding why you're having the procedure that you're having.
I agree. You're spot on on both accounts. It can be an absolutely life-changing procedure in so many ways. It can give patients a shot at living their best life, their healthiest life, and increase their longevity. And so a sleeve gastrectomy or another form of bariatric surgery is genuinely life-changing in so many ways. But at the same time, not all sleeves are the same, not all gastric bypasses are the same, and patients should do their due diligence a little bit, their homework, to make sure that they know what they're getting and know a bit about the experience level and the results that their surgeon gets. Another little clue that may give some insights into whether they're seeing a surgeon that's experienced in this or not would be to ask, do they contribute regularly to the bariatric surgery registry? The BSR was set up many years ago, principally as a quality control mechanism, and it's a nationwide registry that's a voluntary registry that surgeons can opt to contribute to, but they also don't have to by law. Any surgeon that doesn't contribute to the bariatric surgery registry would be a red flag for me. I'd be concerned that the patient is trying to hide their results, doesn't want to have those results up for independent scrutiny. So that would be another question that patients should absolutely feel comfortable to ask. Do you contribute to the bariatric surgery registry? Another question that can give clues is ask the surgeon, do they do a full range of bariatric procedures, not just sleeve gastrectomies? Do they also do gastric bypasses? And if so, what's their experience level with those other procedures? And the reason why that's an important question is that in my experience, colleagues that only perform a sleeve gastrectomy are usually not upper gastrointestinal trained specialists. They are general surgeons that are incorporating sleeve gastrectomies because they are technically easier into the general surgical practice rather than being true upper gastrointestinal bariatric specialists.
Wow. Yeah, I think that's really important and a great question to ask. Is there website or anywhere we can go to find any of that information out? If they have that sort of training, or is it really just up to asking the question of the surgeon at the time?
It's really up to asking that of the surgeon at the time. The only information that you could readily find on an independent website search would just to confirm that that surgeon is in fact a bona fide surgeon, that they do have a specialist qualification, and that they don't have any restrictions on their practice. And that would be found through the APRA website. That's the new name for the old medical board.
Yep.
And that's readily searchable by anyone in the public. You simply type the name of the specialist in, and that will tell you whether they're registered as a specialist and whether there are any restrictions on their practice. But it will not tell you anything about their level of training or
Yeah.
their level of expertise, or whether they have specific additional qualifications that allow them to be called an upper gastrointestinal surgeon. That would really be through asking the surgeon directly. But I would definitely encourage all patients to know a bit more about their doctor, whether it's a surgeon or any specialist. And the first thing that should be done is a quick check on that APRA website to make sure that they have bona fide qualifications and don't have any restrictions on their practice.
Yeah. No, that's fantastic. So for anyone who's listening, who may be looking at having surgery, you mentioned your team do telehealth.
Yeah, we do. Telehealth's become a big part of our care since COVID. Of course, during COVID, it was very difficult for patients and their doctors to see each other face to face. And so we all became geared up around providing telehealth consults, whether it's by Zoom, Teams, or by telephone. And we've continued that. And that's allowed us to really care for patients from all over the country, whereby uh, appointments with the dietitian, blood checks, appointments with the bariatric physicians, the appointments with our psychologists, group sessions can all be conducted in the comfort of our patient's workplace or home without having to physically attend the clinic. And I think that's been a great thing. I do a lot of outreach clinics around New South Wales, and we have patients that come to our clinic from all over the country, particularly Victoria, Tasmania, Western Australia, even New Zealand. And really, that expertise now from our multidisciplinary team can be extended across a much larger canvas than it used to be before COVID.
So and you mentioned, you know, out of state, even from New Zealand. I think that's great because, quite often we get people that go, "No, I just really, felt comfortable with that podcast, and do you think this surgeon would take me on as a patient?" And I think that's great when you have that availability to take interstate patients as well, especially if people that are living in sort of the more regional or remote areas, that they have to rely on telehealth anyway. So I think it's a great opportunity for people to go, okay, maybe this is someone that I can look at starting my journey with. And are your books still open for taking new patients?
Absolutely. And I'd also like to add to that is just get a second opinion. I'd be very happy to give any of your listeners a second opinion on their situation. They
Yeah.
may have a surgeon that they are in regular contact with that's local to them, and they're comfortable, broadly speaking, with that surgeon's care, but they just want to have a second opinion. There's no problem with having a second opinion. I'd be happy to provide that to any of your listeners. And that doesn't mean a consultation with a surgeon doesn't mean you're going to have an operation with that surgeon.
Yeah.
You're just getting some time with that surgeon to, on one, go through your medical history, go through what the issues are, and make recommendations that then you can go away and think about, reflect on, and decide how to best proceed for your own individual circumstances. So I'd encourage that and warmly invite any of your listeners to take that opportunity if they would like to do so.
Amazing. Thank you so much for that. And thank you for joining us today on the Bari Chronicles. Really look forward to our next one.
Great, Damo. Thank you very much for having me. It's always a pleasure. And look forward to the next one as well.
Awesome. I'll just stop.